Hello and welcome. This is the first of 3 videos showing you some of the content that you'll be receiving if you go to the Functional Medicine and Family Tour. Obviously, I really want you to be there, but I wanted you to make an informed decision to see if this is the kind of information that you're looking for. So in this first of 3, we're going to be talking about calculations, specifically one calculation that you may not have heard of, but you need to be using in your practice. And so why calculations? The short version is I have long since believed that on a blood chemistry, if you look at the scientific literature, there has to be ways of extracting more information using the markers that are already on there. And that's the case with calculations. There's a vast amount of calculations, many of which I'll be covering during the weekend. This is one particular one that's been validated. Scientifically, it's validated. It's been compared to the actual thing that it's measuring, and it works. So therefore, there's zero reason why we shouldn't be using these. If we have the markers to use, and if these calculations are scientifically validated and they're measuring what they're supposed to be measuring, why are not we using these things? It can offer more valuable information, which can lead to better treatments and therefore better success with your patients, things that maybe you aren't even considering in the first place. It's not only more valuable to the patients, literally, because you might be managing something that they didn't even know how they had a problem with, but it's also a higher perceived value. Now, in this particular case and video, we're going to be talking about viscosity. And if you tell your patient their viscosity is elevated, they may say, well, how come no other doctors ever told me that my viscosity is high? So then it's not only an actual value, but it's a perceived value as well. And then they probably will put more trust in you. Anyhow, so it's one of a handful of calculations we'll be talking about during the Functional Medicine plus Family Weekend Tour. And Peter Drucker is one of the best business minds of our time. He said you can't manage what you don't measure. And if you're not measuring viscosity, you can't measure it. So now you might think, well, why is viscosity important? I'm going to show you a whole bunch of papers where at the end of this, my hope is you start using this calculation with people right away. There's no reason why we can't. So viscosity obviously is the thickness of the blood. It's how well blood flows through the vessels, whether large ones like the aorta or smaller ones like arterioles or even capillaries. You can see right now, just even looking at this graphic, the more thick the blood, or the higher the viscosity, that would obviously lead to some potential cardiovascular problems. So we'll take a look at that. So here's a whole bunch of papers just showing you how important viscosity is and why we should be measuring it on literally every single patient that walks through our door. This is a paper done on firefighters. You know that they can get dehydrated. So they did a mock fire drill. They were dehydrated. They looked at a variety of markers, including whole blood viscosity, and they found that after they rehydrated the firefighters after this drill, some of the markers improved, but whole blood viscosity did not. And they went on to say that whole blood viscosity measurements were better determinants of hydration states than some of the other markers that we might be using. So you know how important it is to measure or evaluate hydration. It turns out that whole blood viscosity is one such measure that might be more sensitive to hydration than other markers. Now here's a whole bunch of papers showing you what whole blood viscosity is associated with. In this paper, it was associated with silent cerebral infarction. And if you notice what they say down here, that at a low shear rate, and I'll explain that, there's 2 different shear rates that you'll see, is a novel indicator of silent cerebral infarction regardless of classic cardiovascular risk factors. So their lipids might be fine, but if they have elevated whole blood viscosity, they may be at risk for certain cardiovascular issues. Here's a paper that looked at non-alcoholic fatty liver disease, and they found a positive correlation that those that had non-alcoholic fatty liver also tended to have a higher blood viscosity, whether it was causative or correlative, they're not sure, but there's a really interesting paper I'll show you about in just a second. This was a paper looking at type 2 diabetes and arterial stiffness. And what they showed was that higher whole blood viscosity at a low shear rate, once again, indicated more arterial stiffness in patients that had type 2 diabetes. So you might have 2 patients that have type 2 diabetes. You run viscosity on both of them. The one that has a higher viscosity likely has arterial stiffness, more so than the other one. And of course, that's really important information to know. This was a really interesting paper. This basically said that whole blood viscosity was not only correlated with type 2 diabetes, but if you look at this here, is an independent risk factor for type 2 diabetes. The short version is they said that if the blood is more viscous, it's going more slowly, things like glucose are staying in the blood higher or for longer periods of time, thus leading to more insulin being released and basically being a causative factor of type 2 diabetes, which is a really powerful thing for them to go ahead and say, talking about that it leads to the development of insulin resistance in type 2 diabetes. So again, if you're not running viscosity in people, then you might be missing this. Similar to the other one, this paper looked at people that had non-alcoholic fatty liver disease. Those that had higher blood viscosity had more arterial stiffness. Now, another quick thing I'm going to show you about this paper, and I'll be talking at great length about this during the weekend because there are ways of evaluating fatty liver far better than what we're currently doing. So this was in men. Now just look at this really quickly. Here's AST and ALT. Now every single one of these individuals in this study had fatty liver diagnosed by ultrasound. But look at those markers. We would normally use AST and ALT in order to evaluate for potential liver dysfunction, but these are fairly normal numbers. And that was in men. And again, you look at women, it was even worse. These women all had fatty liver, but look at their AST, ALT, and GGT. They were just fine. Most practitioners would not look at these markers and think that they had fatty liver, but in fact that they did. So that's an aside. We're talking about that during the weekend as well. This was a quick paper that basically said that whole blood viscosity was associated with, was positively associated with osteoporosis and negatively associated with bone mineral density, meaning the higher the viscosity, the lower the bone mineral density. Again, causative or correlative. This one was a great title, The Forgotten Variable of Shear Stress, which is looking at, of course, whole blood viscosity. The thicker the blood, the more shear stress it's causing on the blood vessels. And something called mitral annular calcification. And basically what they said, that those that had mitral annular calcification had a higher whole blood viscosity, which independently predicted the presence of this in the first place. So if we're not measuring viscosity in people, and I'll show you how easy it is, this is preceding, as you'll see even in a minute, endothelial dysfunction, cardiovascular issues. And down here, I'll explain this later, but these were individuals, this was the high shear rate and low shear rate of individuals that did not have mitral annular calcification. And here's the rates of people that did, and you can see that they're higher. So we'll talk about how to calculate that in a second. This was a great paper. Blood viscosity in people that had normal glycemia conventionally. So they had three groups. Group A had glucose lower than 90. Group B had between 90 and 99 in the US units. And then group C had elevated glucose. And what they said is that blood viscosity was significantly higher in B and C compared with group A. And they went on to say that even in group B, which they considered to be normal glucose, that's conventionally, of course, it suggests that even with glucose values that are normal, individuals with higher blood glucose levels have increased blood viscosity comparable to those with pre-diabetes. And this speaks to that other paper that said maybe that this is actually causative of insulin resistance and diabetes in the first place. Again, why are we not measuring viscosity? Why have we not heard about this? Whole blood viscosity is associated with gallstones at a low shear rate, independently associated with it. Here's a quick, this is the blood viscosity. The higher the blood viscosity, the more likely people had gallstones, which is interesting. And simply, this paper here I thought was interesting because in the next video, we're going to be talking about bilirubin, which you probably heard before, but probably not in a way that I'll be talking about. But bilirubin is a marker of oxidative stress, which I'll talk about. But look at this. Whole blood viscosity was an index of the macrovascular effect of oxidative stress. So it's not necessarily looking at specific oxidative stress, but if there is oxidative stress, then that could be one of the potential causes for increased whole blood viscosity. And then lastly, this paper looked at whole blood viscosity as a marker of endothelial dysfunction, which would make sense causing there's an increased shear rate. But what they said, and I'll just read this. Therefore, as plasma viscosity is a sensitive parameter and easily measured, it can add useful information about the diagnosis and treatment of various disorders, as we've seen, and it should be utilized more frequently in clinical medicine. In fact, the original paper that came up with the calculations for the viscosity, which I'm about to show you, said in the conclusion, because this is so easy to measure, because it's accurate, they measured it to actual blood viscosity. They said every physician essentially should be running this on every single patient. So quickly, this was a paper, and this is showing you that I do my due diligence when I present any information. This was a paper that basically said, okay, so here's this equation. It's been validated. However, researchers, you're using it all wrong. And this is because the markers used to calculate this can be written differently. So in some places, total protein is grams per liter, and it might show up as 70 grams per liter. And other places like the US, it's grams per deciliter, and you might have 7.0. Well, researchers are using either one of these in the equations, and it turns out they kind of work, but not always. Also, hematocrit is typically written as a percentage, but you can convert that to a decimal. So research that's been using this equation is all over the place when you look at the values that they come up with. But this paper said they took 5 different ways of doing this, and they said this is the best way. These are the markers that you need to be using in these measurements. And that's what I'll show you. So I looked at this paper, and the equations you're about to see are as accurate as they could possibly be. So here's the high shear rate. I'll show you the low shear rate in just a second. It's very simple. It's the quantity of 0.12 times the hematocrit, in this case it's 44, plus the quantity of 0.17 times the quantity of the total protein, minus 2.07. So if I use these values here and plug them in, here's the hematocrit, here's the total protein, and this is the viscosity. Now this, I will tell you, is not an evidence-based reference range. There are no reference ranges, and unfortunately, like I said, papers are all over the place with this. But what I did was I took the high end of an optimal hematocrit and protein, a low end of an optimal hematocrit and protein, and I plugged them in. Now, because men and women have different hematocrits, I have a male and female version of this. This is not evidence-based. This is what I've done. But looking at the studies, these ranges match up pretty well. Notice here I don't have the low shear rate. I'm going to include those in the weekend. But here's the low shear rate at 1.89 times the hematocrit. Again, we'll just make that up as 44. Times the quantity of 3.76 times the quantity of total protein minus 78.42. And if you plug in the proper total protein there, then you get 51.5. Now, as a case study, here is an individual that ran 4 blood chemistries. One was in January and February, the next was in June, and then following in July. He did a 10-day detoxification program between each time. And you can see down here, I'll just show you how you can use this, is here is the high and low shear viscosity. Oh, by the way, so I mentioned this, but high shear viscosity is in arterioles, low shear viscosity is in larger blood vessels like the aorta. So you can see that the original viscosity decreased after merely doing a 10-day detox in a 30-day period of time. Once again, he kind of fell off and did his own thing, and it wasn't as healthy. But then when he came back, here was the viscosities pre-detox, did a 10-day detox. And then afterwards, you can see there's a marked improvement in this one especially. So that's great. And if you look at all the associations of viscosity, which we'll look at here, you can see that you're probably helping this patient. It's another marker that we can be tracking. So it's a better measurement of hydration than other markers. It's associated with all sorts of things like viscosity is silent cerebral infarction, fatty liver, atherosclerosis, gallstones, arterial stiffness in type 2 diabetes in people with non-alcoholic fatty liver disease, osteoporosis. It's negatively correlated with bone density or bone mineral density. It's associated with cardiovascular disease more. It may precede and be a causative factor of type 2 diabetes. It may indicate the macrovascular effect of somebody that has oxidative stress, and as I think I've shown now, should be utilized in every single patient, in every single clinical practice, because this is a silent issue that is the forgotten issue, like a couple papers have said, that we need to be looking at. It is another marker that we can use, that we can evaluate our patients with, that we can treat, and we can see improvements in. So there's more calculations that I'll be covering. That's one of them. Space is limited. If you're interested, if you like this and you want to go for it now, go ahead and book yourself one of the cities near you. But if not, tomorrow I'll be talking about markers that you may not have heard about, but you need to know. Thank you so much for your time.